Hello and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Jessica Adams. In this episode, Dr. Carolyn Chu discusses how HIV-ASSIST can be used to choose ART for people with HIV with hepatitis B and hepatitis C coinfections. Dr. Chu is the Chief Clinical Officer at the National Clinician Consultation Center and a professor in clinical family community medicine at the University of California, San Francisco in San Francisco, California. For the full online educational program, please visit the link in the show notes for this episode. Now let's get started and hear what Dr. Chu has to say.
Primary care providers are needed to help address ongoing nationwide HIV-focused healthcare professional workforce shortages. It really can't be emphasized enough that PCPs are important to ensure comprehensive and coordinated medical care for people with HIV and also to expand access to HIV prevention options, especially in communities that have been or may be heavily impacted by HIV. Although the need for primary care integration with HIV services is not new, antiretroviral therapy decision-making and epidemiologic patterns of co-occurring conditions have shifted and now, more than ever, necessitate primary care involvement in HIV care. Educational tools like HIV-ASSIST have been designed to support delivery of evidence-based HIV care by HIV specialists and non-specialists by incorporating current clinical guidelines with relevant individual patient factors in order to create personalized antiretroviral therapy options. Additionally, HIV-ASSIST uniquely streams antiretroviral decision-making for healthcare professionals through an easily accessible interface that not only directs users to relevant guidelines-based information, but also provides detailed supplementary context by consolidating multiple educational resources. HIV-ASSIST can therefore be a time-saving aid for busy healthcare professionals. Additionally, real-time incorporation of the use of HIV-ASSIST into clinical encounters may also help facilitate patient engagement and collaborative information sharing. So let's think through some specific examples in HIV co-infection with hepatitis B virus or hepatitis C virus. The Centers for Disease Control recently released updated Hep B screening and testing recommendations, adopting a much simpler and inclusive approach that will hopefully ease implementation challenges and advance the U.S. toward meeting its viral hepatitis elimination goals. Similarly, last fall, the American Association for the Study of Liver Diseases updated their Hep C testing, management, and treatment guidance to indicate that HIV infection is no longer considered a contraindication to adopting a simplified Hep C treatment approach. Current and future HIV care providers should be familiar with evolving viral hepatitis guidelines and best practices, as Hep B, Hep C, and HIV have long-standing connections. In addition to sharing routes of transmission, co-infection may be relatively common in some at-risk populations, and careful medication selection and clinical monitoring is warranted when co-infection is present. For people with HIV Hep B co-infection, HIV-ASSIST can be highly useful to ensure appropriate antiretroviral therapy selection, including the consideration of hepatic dysfunction when present. For example, for a person with newly diagnosed HIV Hep B co-infection who has Child-Pugh Class A liver disease, the tool identifies several preferred antiretroviral therapy options based on the likelihood of achieving HIV viral suppression and maximal medication tolerability. The options include co-formulated bictegravir, tenofovir, alafenamide plus emtricitabine, or dolutegravir plus emtricitabine, tenofovir, alafenamide, or doravirine plus emtricitabine, tenofovir, alafenamide. ASSIST also highlights that inclusion of tenofovir, alafenamide, tenofovir disoproxil fumarate, lamivudine, and emtricitabine have all been prioritized since these drugs have activity against both HIV and Hep B. Alternatively, if a streamlined two-drug regimen approach to HIV treatment is preferred, for example, in scenarios where tenofovir exposure is not desired, HIV-ASSIST appropriately notes that persons with HIV Hep B co-infection will still need an additional Hep B treatment agent if they were to transition to dual therapy with dolutegravir or lamivudine for their HIV treatment. If we now turn our attention to Hep C, PCPs providing HIV care are again well-positioned to offer Hep C screening and treatment. One key feature which may be particularly helpful is ASSIST's drug-drug interaction checker, which has been integrated into the platform. This resource can be easily used to assess for potential drug interactions between a person's antiretroviral therapy, other co-medications, and Hep C treatment options. For example, a person whose HIV RNA has been stably suppressed on the single tablet combination of darunavir, cobicistat, F-TAF, and is now planning to start Hep C treatment may need to consider switching antiretroviral therapy if the direct-acting antiviral combination of glecaprevir-pibrentasvir will be used. This is because co-administration may increase systemic glecaprevir concentrations. Interactions like these are easy to identify by using the HIV-ASSIST drug-drug interaction checker, which is integrated with the University of Liverpool's HIV drug interaction checker.
Thank you very much to Dr. Chu, and thank you to our listeners for joining in. To get more from our program, see the links in the show notes. You can view webcasts on the HIV-ASSIST tool, hear additional case examples, and see comments from other experts. Please be sure to check back regularly for more episodes on important infectious disease topics. Thank you and have a great day.